Hello, welcome to this next lecture that I'm giving. Again, I'm Tim Hamill. I'm Emeritus Professor of the UCSF Department of Laboratory Medicine, and today we're going to be talking about point-of-care testing, or POCT, as you'll hear me call it a lot in this lecture. Again, as with my other lectures, I break this into chunks. What is point-of-care, the point-of-care regulations, point-of-care oversight issues, and then the top 10 deficiencies that laboratories experience when they are inspected on their point-of-care. So I break it down, take some breaks in between those, and go back over them a couple of times. It's pretty straightforward stuff. But if you have any questions, as per my prior lectures, don't hesitate to give me an email or drop me a line, and I will get back to you as soon as possible. Okay, so goals and objectives. Describe what point-of-care testing is and the tests commonly used in point-of-care. Describe why blood pressure isn't point-of-care. Describe the regulatory requirements for waived point-of-care testing, moderately complex point-of-care testing, and provider-performed microscopy. You'll remember these terms from my prior management lectures. Describe common point-of-care oversight structures. Describe the important components of the point-of-care oversight team. And what's the number one deficiency point-of-care testing labs get cited for? So, what is point-of-care? Well, there's no strict definition of point-of-care, although most point-of-care follow some general patterns based on either the location of where the testing is performed, the test methods that are used, and the test complexity levels that are used, and the personnel performing the testing. So why do we have point-of-care? Why not just do everything in the clinical laboratory? Well, the perceived advantages, especially by clinicians, is that point-of-care is rapid, and therefore the provider isn't waiting for a sample to get to the lab, for the lab to test it, and for the lab to report it back. They would have an answer in their hand very quickly and could make a clinical judgment based on that. In the outpatient setting, there's a perception that there's better patient satisfaction because, again, the patient is not waiting for the doctor to get a result and then phone them and discuss whatever they're going to change in terms of their treatment. Maybe there's better patient throughput through clinics because instead of waiting for tests to come back, you can get the patient in and out very quickly. And there's a perception that there's money to be made doing point-of-care testing. Potential disadvantages. Well, there are accuracy limitations. Most of these are point-of-care type tests are not as accurate and reliable necessarily as in laboratory performed tests. And some of these tests may require that the laboratory perform a confirmation test before the patient can actually be diagnosed. A good example of this is HIV testing. HIV positives must be followed up with an in-laboratory test. Sorry about that. There are regulatory requirements, which most people who want to set up point-of-care don't really recognize that there are regulatory requirements, and there's significant cost to setting up point-of-care that may outshadow any potential revenue that can be generated from it. So point-of-care sites and locations. As the name implies, point-of-care generally occurs at the point of patient encounter and usually coincident with the patient encounter. So in the inpatient side, it'd be at the patient bedside. It can be done in a clinic or a physician's office. It could be done in a procedure area. So the operating room may do point-of-care testing, the emergency department, radiology, the delivery room. Those are sites that may do point-of-care as part of their procedures that they're performing on patients. Can occur during patient transport. So ambulance personnel, EMTs can perform point-of-care. Might be performed at pharmacies, health fairs. Dentists can perform point-of-care. There's lots of places where patients may encounter point-of-care type testing. Testing performed in what we would call satellite laboratories, so a stat lab in the emergency room or the OR, are not generally considered to be point-of-care. These are typically considered just another laboratory controlled by the central laboratory, and therefore are not necessarily considered point of care, even though they're close to where patient care is being performed. Blood gas labs are not generally considered point of care. If you're doing blood gas testing at the bedside, yes, with say an iStat, that would be considered point of care. If you're drawing a sample, an arterial sample, and sending it to a blood gas lab, that's not considered point of care testing, as we're kind of trying to define it in these lectures. Labs associated with infectious disease isolation units. So at UCSF, we set up an Ebola highly infectious containment unit when the Ebola outbreak occurred, and we had a laboratory that was within that containment envelope, and testing would be done there. Again, wasn't considered point of care, even though we were literally right across from the patient bed across a hallway. So, point of care tests. Well, the vast majority of tests used in point of care are simple, rapid, waived or moderately complex tests. And there's a huge number of vendors out there that produce point of care tests or try and get their tests adopted as waived or moderately complex so they can be used as point of care. At the simplest level, we've got visual endpoint tests. So things like occult blood, pH, urine dipsticks, pregnancy tests, rapid strep, influenza, COVID-19, rapid drug screens. Those are all visual endpoint tests because they're read by the person doing the test in a visual manner. Handheld instrumentation, such as blood glucose meters, the HemaQ for hemoglobin testing, or iStat chemistry that can perform a number of different tests, would be a type of point of care that has a small instrument. And then you have small tabletop type instruments like the Piccolo, activated clotting times, thromboelastogram, Rotem, BioFire. And if you go to the URL that I've listed below, you can see the list of CLIA analytes that are waived complexity and can be used as point of care. There are many others that are moderately complex that can also be used, but this is a good starting point for getting used to what types of tests are used at point of care. Okay, so here's just some examples of visual endpoint tests. This is an occult blood. Here's urine dipsticks. We've got a pregnancy test. Here's a narrow pH called Hydrian paper that is used for amniotic fluid testing. Here's a drug collection container, a urine collection container that measures for drugs right in the wall of the container. It will do essentially a dipstick test to detect drugs. Here's the Abbott COVID-19 antigen test, Binax Now influenza, and this is a rapid strep test. Versus handheld instruments. So here's a little point of care analyzer that does immunoassays. This is a blood glucose monitor. This is another blood glucose monitor. This is the iStat, which can do a number of different tests depending on what cartridge is used. And this is a HemaQ, which looks at hemoglobin levels. And then the small instruments. So here's a Piccolo chemistry analyzer. This is a thromboelastogram. This is the counterpart of it called a Rotem. This is an ACT or activated clotting time machine. And here's a biofilm test for infectious disease, the BioFire. Okay, so we kind of know what point of care tests, where they are, what kind of tests they are, but is all testing that's done at the patient bedside or near the patient considered point of care? Well, based on the wording of CLIA and the definition of a laboratory that includes, quote, materials derived from the human body, end quote, not all tests are point of care. So there's things called a Billicheck. And the Billicheck is used in the neonatal unit. It uses reflectance of light off the infant's forehead to estimate their neonatal bilirubin level. Doesn't require a sample to be derived from the patient. It's just light bouncing off their skin, so there's no sample involved. Therefore, it doesn't meet the definition of a CLIA test, and therefore places doing it are not required to be a CLIA laboratory. Pulse oximetry is another one. Pulse oximeter just fits on your finger. You've probably all had these done. Again, it is light transmittance and reflectance, and it will give you oxygen saturation and a pulse reading. So again, because no sample is derived from the human body, a pulse oximeter is not considered a laboratory test, even though it measures something, as does a ability check, that can also be done in the clinical laboratory. Okay. Provider performed microscopy. This, by definition, is performed near the patient and is performed by persons authorized by regulation and training, so MDs, DOs, some mid-level practitioners, to do provider performed microscopy. The allowed tests are potassium hydroxide, or KOH, usually done on skin samples to look for fungal elements. Wet mounts, usually done on vaginal fluids to look for yeast, clue cells, trichomonas, those types of things. Urine sediment exam, looking for crystals, white cells, those types of things. Qualitative semen assessments, which mean, since it's qualitative, it's just, yes, they are there, and yes, they are moving. That's all you can really tell about it. There's no counts, there's no morphology or any of that. It's just, yes, this semen sample, there are sperm present, and they are moving. Ferning is kind of an unusual one. It's not done much out of the OB suites, but ferning is where vaginal fluid is placed on a glass slide and allowed to dry. If amniotic fluid is in the sample, then you will get this interesting fern-like pattern as the sample dries, and you can observe that under a microscope. Postcoital exam, typically looking for sperm. Pinworm exam, so, taking a sticky swoob paddle or tape near the anus, putting that on a slide, the tape on a slide, looking at it under a microscope for pinworm eggs. Nasal leukocytes, allergies and those types of things, and fecal leukocytes for GI disorders. Note that the last two require staining, and therefore lots of places don't do these because of the complexity of keeping stains up to date, stain precipitants, those kind of things. So those two may be less common when you go out and look in the point of care world. Okay, can a laboratory do point of care testing? Well, sure. Laboratory could go out to the patient's bedside and perform point of care testing, and I've certainly seen institutions that do that. It's not a very efficient use of your lab staff. They're spending time going out to the patient's bedside. They may be waiting around to perform the test until the patient is ready, and then they've got to come back to the lab. So you've got a lot of lag time in there where they could be in the lab actually doing testing. Tests marketed for point of care use, wave tests and moderately complex tests, can certainly be done in the laboratory, but most of the advantages of point of care are lost. You're losing your rapid turnaround time. You are losing the ability to get a quick answer into the hands of a clinician to work with. The laboratory inspections, when your inspector comes in, they're going to look at those tests and say, well, I expect you to treat those all, even if it's waived, as moderately complex. I'm going to expect you to do proficiency testing, even though for wave tests in a point-of-care setting you don't have to. We'll talk a little bit more about that. But they're going to expect that each test in a laboratory is handled like every other test. Some tests can simply not be performed or should not be performed in the laboratory. Activated clotting time is one. Once you put patient blood into the tube that activates the clotting process, it starts immediately. You cannot run that sample down to the laboratory, drop it on a machine, and expect to get any kind of reliable answer out of it. You've missed the first few minutes of the clotting time, and that's usually where we want to know what's going on with the patient. So some things really, if you're going to do them, you have to pretty much do them at the bedside. Okay, who performs point of care testing? This is another thing that separates it out from the clinical lab. True point of care is almost always performed by non-laboratorians. It's performed by physicians or nurses medical assistants, EMTs, virtually anyone with a high school diploma in a physician's office can do this testing. And this creates one of the biggest challenges for a point-of-care program, and that is keeping up with staff training and competency. We'll talk more about this, but this is a huge challenge because in a laboratory you've got an encapsulated group of individuals. You are doing competency assessments on them and watching them all the time, looking at their turnaround times and stuff, whereas you may have 10-fold that number of individuals in a hospital, 100-fold, who may be doing point of care, and now you've got a huge issue with how do you manage their training and competency and make sure that everyone's doing this testing correctly. Institutions may choose to limit who can perform point of care based on patient location, and I think this is a really good idea. So I know at UCSF, when I was there, if it was an inpatient location, it had to be a physician or a nurse that was performing the point of care. Why? Because typically in the inpatient setting, you're using that point of care test and making an immediate clinical decision, like I'm getting a blood glucose and now I'm changing the insulin level that the patient is giving. So the feeling was that should be left to either an RN or a physician to do. In the outpatient setting, might do a glucose just to check what the patient's glucose is. I probably am not going to do any major, give them insulin or do anything right there in the clinic. I may say, hey, your glucose is too high. I may need you to go into the emergency room or whatever, but I'm not making a therapeutic adjustment right there. Therefore, it was felt that lower level individuals could probably do that testing just fine. Okay. What are regulations impacting point of care? Well, we've talked about CLIA in my prior lectures. CLIA has a test complexity model and specifies what sites must do to be compliant and what type of CLIA certificate is needed, depending on the type of testing they are doing. There may be state and local regulations, and there may be state licensure. So we'll go through these. So if you're doing only wave testing, then you get a CLIA certificate of waiver. You're required to follow the manufacturer's instructions, and this implies that staff have been trained and shown to be competent on performing the test. Proficiency testing is not required. However, if you're inspected by CAP for your point of care, they're going to want to see proficiency testing performed, even if it's a wave test. You must document your quality control and patient results. You must register in California with the state, but there's no license or fees required. Interestingly, in California, and this was passed a little less than 10 years ago, that California allows licensed CLSs to actually direct waived testing labs. So, in clinics, pharmacies, those kind of things, as places come up that are doing only wave testing, a CLS could be the named director for that laboratory. And this is a new opening for CLSs in the state, and I know of no other states that are allowing this at this point. Okay, provider perform microscopy. If the site is doing that, they need a CLIA certificate of PPMP. That would also cover any wave testing performed at the same location, so you don't need a separate certificate of waiver if you're doing PPM and wave testing. The providers who are doing it should have received training and demonstrate their competency. Tricky to do that sometimes. We'll talk more about that later. Proficiency testing. Tricky. Proficiency testing under provider perform microscopy. If you send around a proficiency test sample, typically it's going to be one provider in each clinic or location that does them all. So you're not really getting a sense of, are the other providers any good at doing this? In some ways, it may be better to have an online competency program that every provider has to go through on, say, an annual basis to demonstrate that they can actually identify a trichomonad in a wet mount preparation or yeast, or identify crystals appropriately in a urine. Must again register with the state of California, but there are no licenses or fees required for provider perform microscopy and waived. Okay, moderately complex testing. Well, now you have to have a CLIA certificate of compliance or accreditation. You must have a named laboratory director. You must follow the manufacturer's instructions and have a written procedure manual, not just insert the manufacturer's instructions into a binder. You must have documented staff training and competency assessments. You must do proficiency testing and be graded on your proficiency testing results. You have to document your QC and test results. The lab must submit to biannual inspections. And in California, a state laboratory license is required, and that means fees. High complexity testing. Pretty uncommon to see high complexity testing done as point of care because of the regulatory requirements and costs. It requires full compliance with CLIA regulations, and in California, the regulations limit who may perform testing. For high complexity testing, really only an MD would be allowed to do a highly complex point of care test. Nurses in California are precluded. At the highest level they can perform is moderately complex. They cannot perform high complexity. We'll talk a little bit more about that when we talk about an issue that came up with glucose meters a few years ago. Note that point of care sites can fall into a high complexity trap, even if they're using waived or moderately complex tests. According to CLIA, any modification or change from the manufacturer's instructions automatically makes that test high complexity. So most commonly this occurs using a test on a non-standard sample type. So you use an occult blood test for breast discharge to see if there's blood in it. It was done a long time ago. It's not a very useful test. Or using a glucose meter to determine the glucose value from a pleural fluid. It's not meant for that. The matrix of the sample is different. It's unlikely that it's going to produce an accurate result, and therefore using it in that way changes what the manufacturer intended, and therefore that waived test in the case of a glucose meter is now high complexity, and you would be judged on that if it was found that you were actually using it inappropriately. Okay, so here's one that virtually every hospital in the United States got caught on. After using glucose meters in hospitals for a couple of decades, the FDA sent out a draft guidance in January of 2014 saying that the use of blood glucose meters in, quote, critically ill patients was considered a high complexity test. And this came out of concerns that blood glucose meters were not accurate due to poor capillary perfusion in patients with hypotension, shock, and sepsis. And if the patients were getting certain drugs that could impact measurements, such as maltose, which may be used in drugs to stabilize different drugs, galactose, another, xylose, another. So things that might give you erroneous results on a glucose because they're another type of sugar. The FDA would not, in their draft guidance, would not define critically ill, and they left it to each individual institution to create that definition. Now, the FDA argued that the glucose meters had not been evaluated for use in such patients during the FDA approval process, and therefore they were backtracking and saying, whoa, you can't use these in critically ill patients unless you want to make them high complexity. So even though they had been in use for decades, suddenly we had this sea change of, oh my gosh, I can't use a blood glucose meter in an ICU or an OR or an emergency department, any place where patients might be critical, quote unquote, whatever that was. Also, nurses did not meet criteria for high complexity testing virtually anywhere in the United States. So nurses couldn't perform testing anymore. Okay, now you're going to have physicians do all this testing. They threw up their arms and said, we can't do it. And labs, after doing tons of point-of-care glucose testing for years, suddenly were asked to accommodate a huge increase in glucose test volumes while still keeping up a good turnaround time. And that was pretty much impossible for labs to do. So what happened? Well, vendors scrambled like mad to produce data to support the use of their meters in critically ill patients. Nova was the first vendor to receive FDA approval, but it was for venous samples. So going back to that, there was a worry that capillary samples might not reflect venous levels of glucose because of hypotension or capillary bed constriction or sepsis or shock. Moving to a venous sample, which is what almost all ICUs and ORs and even emergency departments tended to do, was they tended to use samples from veins anyway, from venipuncture. But because Nova was the first to receive approval, many hospitals switched en masse to the Nova system, and it was complete chaos. Suddenly, within weeks, they had changed over 400, 500 glucose meters and retrained everybody in new ways to control, use the meter, So it was a major headache for most hospitals. Hospitals scrambled to comply. So again, lab staff or physicians to perform bedside testing, that wasn't going to work. Could they curtail blood glucose monitoring? Not really. It was too necessary for patient care. Moved to venous blood rather than finger stick, and virtually every place did that. They were already doing it that way. And narrowly defined critically ill. So at UCSF, I defined critically ill as anybody with hypotension, peripheral vascular constriction, shock, or sepsis, anyone that was receiving any kind of sugar substance, say in a drug like maltose, where it could confound our glucose meters, and very much essentially set a critically ill definition to what the manufacturers had already said. These ones are problematic, you shouldn't use it in these ones. And so we did that, moved to venous blood, and we were inspected and we were fine. Nurses subsequently successfully argued nationwide that their education met the criteria to do high complexity testing, and so they were then allowed to do this testing nationwide, except in California. California specifically states nurses may not do high complexity testing. So now most vendors have received the FDA approval based on using venous samples, and we are continuing to use blood glucose monitoring at the point of care in ICUs, ORs, EDs, wherever, as wave test, and we're doing just fine. Okay, point of care oversight. So in a physician office, the practitioners themselves are the ones who should be providing the oversight, but often this is going to fall to an untrained office manager or vendor reps. In institution, depending on the organization's size and complexity, this often requires some kind of dedicated point of care oversight staff and some form of governance structure. So let's go over some structures. So no structure. Okay, I call this the Wild West. This is typically where pathologists and labs get involved with point of care. Individual sites have full autonomy. They've chosen their own methods. There may be 5 or 6 different types of glucose meters in use. There's little coordination with the clinical laboratory. The CLIA, quote, directors are a mix of individuals, and they may have little or no understanding of laboratory testing, test validation, or regulatory issues. The policies and procedures are fragmented if they have them at all. There is no clear delineation of responsibility or authority, and virtually no process control. Inspections in these kinds of institutions are typically nightmares. So Joint Commission comes in, TJC, and looks at your point of care and says, whoa, you guys have got a mess. And that's typically where the lab gets called and said, I'm the CEO, we got a mess here, Mr. Lab Director, Mrs. Lab Director, you've got to come in and help us with this. So that's typically where point of care starts out. Now, one idea is to have the point of care controlled entirely by the central laboratory. And in smaller institutions, this may be perfectly acceptable. It has the advantages of that the lab staff are overseeing everything. They have a good understanding of test issues, validation, quality control, quality assurance, and regulatory requirements. It allows you to standardize tests across the institution, similar policies and procedures across the institution, and it has clear lines of responsibility and authority. Issues that would need to be considered would be how you're going to break up the CLIAs. Are you going to have the lab CLIA provide full or partial umbrella coverage over all of the point-of-care testing sites, say on the inpatient side? Well, there are risks to that. What if you get inspected and one of your testing sites has really gone off the rails and they get major cited to the point that they're now looking at the main lab's CLIA and saying, well, you're covering that site, we're going to suspend your entire CLIA. That means the central lab can't test, you can't bill CMS. It could become a real major issue for an institution. What do you do with remote sites? Typically, CLIAs can go over a building or conjoined buildings kind of at the same address, but once you get at a different address on a different campus, that's going to have a separate CLIA. There is a limitation for directors for moderate and high complexity testing. Gosh darn it, they keep popping up. That a director can only have 5 moderate and/or high complexity CLIAs underneath them. They can't have any more. There's an unlimited number of waived CLIA certificates that a director can have, but no more than 5 moderate and high complexity ones. Will the lab director be the point of care director? A lot of them would not want to take on this responsibility in addition to being the director of the clinical lab. Is the director comfortable with mandating when, where, and what point of care will be approved or allowed? I mean, whoever is going to be the point of care director can be seen as a big black hat. Everyone likes and wants point of care, but if you're the one who's out there saying, no, you don't get this, no, you don't get that, no, it has to standardize to this instrument or this type of test, they don't like that. And does the director really have sufficient control over staff for point of care? I mean, a laboratory director really doesn't have direct line authority control over nursing staff or over physician staff. So if you find staff are doing things inappropriately, what is your ability to control those staff, prevent them from doing testing, remove them from doing testing? You may find yourself at odds with other areas within the institution. Okay, the blended model, this is probably the most common model, especially in larger organizations. You have centralized oversight and control, but distributed responsibility. So the CLIA, typically what you're going to say is the laboratory, and we'll get to a point of care committee, is going to provide oversight for point of care for the entire institution, and each point of care site is responsible for maintaining their regulatory compliance, competency, and those kind of things. So, centralized governance, distributed responsibility. The central lab CLIA may provide some coverage, as we talked about before, or you may want to have them completely separate. Multiple CLIAs for various portions of point of care. So you might have an inpatient point of care CLIA, an outpatient point of care CLIA if you've got like a clinic building, and then remote sites having their own CLIAs. Issues that may come up: is there an overall point of care director? And if so, who is that? Establishing the organizational oversight structure, so establishing the responsibilities and lines of communication and authority. So you've got to get these, you've really got to go to like the medical staff and the C-suite, CEO, CFO, and say, you have got to authorize that, we're going to send up, we're going to set up this structure, and you've got to give this structure the appropriate authority to do what the structure needs to do, or we won't be able to maintain quality and regulatory compliance. It requires constant management and attention, or the system will degenerate very rapidly, months into the Wild West again. And then there may be some ownership considerations, especially if like 2 hospitals are joining. Okay, you run different glucose meters, are you going to have to standardize who owns them, those kind of things. So ownership considerations may have to be taken into account, hopefully not. Okay, so the blended model virtually requires the formation of a committee to provide organizational oversight. What does this committee do? Well, first off, they're an advisory committee. They will look at medical utility of various tests, do cost assessments for setting up point of care testing, help select point of care testing. So which glucose meter are we going to use out of the 20 that are out there on the market? Review new tests or location requests for approval. So I've got a current site, but they want to add a new test on. Okay, that needs to come to the committee for approval. Or I've got a brand new site that wants to start up testing. That should come to the committee for approval or disapproval. What is the request process? You need to set that out. So how do sites request new tests or a site request point of care testing to start out? The point of care committee should monitor the sites for their quality control, quality improvement, proficiency testing, and compliance with regulations. This is probably going to require some kind of audit process that then feeds information back up to the committee. And then the committee needs to be able to say, this site is doing so badly, we're going to cut off your point of care testing abilities until you can get all your ducks in a row and show that you can maintain the level of quality and regulatory compliance that is required. Okay, so who gets onto this committee? Well, it should represent the people who are interested in point of care. So clinical laboratory might have multiple laboratories involved. Nursing, they're going to be involved in testing a lot. Material services and purchasing. We'll talk a little bit more about that, but I think that's very important to have in there because they're going to be distributing a lot of the point of care kits and devices. The IT folks, because they're going to be involved if there's instruments that upload data, or they're going to have to be entering data into the computer to set up the appropriate tests, because you want to know that, oh, this glucose was done as point of care versus this glucose was done in the central lab. You've got to know where it was performed and by who. Hospital administration may want to be involved. The point of care testing areas that are heavy users, so an inpatient representative, maybe an outpatient representative, the operating room, the post-op room, OBGYN, radiology, whoever wants to use point of care, especially if they're moderately complex tests, should probably be at least have someone representing them on the committee. Other physicians, other individuals in the institution, patient advocates, lots of different people. You need to strike a balance, however, between representation and committee size. I mean, my feeling is that over about 12 to 15 people maximum, a committee becomes totally unwieldy. And so you've got to tread that line of trying to get all the stakeholders represented, but keep the committee as small as possible, which may mean you bring in people as ad hoc participants whenever, oh, well, we're talking about point of care testing in the OR. Let's bring in someone from the OR to help us with that. Oh, we're talking about point of care testing in a new clinic. Let's bring in a person from the new clinic. We're talking about a different type of point of care testing we haven't done. I don't want someone from the laboratory who knows chemistry, blood gas analysis, whatever, to sit in just during those deliberations. And then someone's got to chair the committee. So that could be the lab director, could be some other dedicated pathologist, or could be a physician. And in some cases, having a non-pathologist chair the committee, it really adds some weight. It's not just the laboratory saying through the committee, you have to do this. It's their own peers saying, no, you have to do this. Okay, so duties of the committee, well, develop all the policies for the program. So the CLIA structure, the point of care request review and approval process, how are results going to be reported, manual versus electronic, normal ranges, critical result notification, how you're going to document changes to procedures and policies, and revocation of point of care authorization. Review provider point of care authorization and or credentialing. You're going to have training programs. You're going to have proficiency testing results. You're going to maybe have audit results. Those should be all coming back into the committee to review. If the committee will evaluate those requests for new point of care sites and tests for, is it medically justifiable? Is there a real need here? Or is it just, ooh, it's a new whistle and bell and it sounds sexy, but it's really not medically appropriate to do as point of care? And is it cost effective compared to the main clinical laboratory? Almost guaranteed that the main clinical laboratory is doing things for pennies, whereas point of care testing may cost dollars. So it is the advantages from doing a point of care test sufficient to justify the increased cost. Review the site compliance with quality control, quality assurance, storage of materials, all those kind of things via audits and the point of proficiency testing data. And then annually review the program and make changes to it as appropriate. So those are the main duties of the committee. They'll get into lots of other things. The point of care team then, especially in a large institution, you really need a team of individuals that are really dedicated to the care and feeding of the program. The lab director, or whoever is in charge of as the point of care committee chair, or a pathologist that's over point of care, may lead that team, but the team needs a really strong supervisor / coordinator to manage point of care on a day-to-day basis. Pathologist, laboratory directors, those folks are pretty busy. You really want a really strong person that can oversight it and just bring major issues back to the committee or to the director. Depending on the size of the program, there may have to be 1 to several additional dedicated point of care FTE on the team. At UCSF, we ended up having 6 individuals dedicated to point of care that were under the clinical lab. Lots of other people involved in it, but dedicated CLSs in our process. Need to think about who the technical consultant's going to be. This could be the lab director. If they're a pathologist, you could bring in ad hoc members with special expertise, but you've got to meet that technical consultant requirement for a CLIA moderately complex testing site. Okay, duties of the point of care team then. Well, do initial evaluations of tests and kit devices based on new requests. Do validation of whatever is approved, write up point of care procedures, coordinate training with nursing and physician staff, development and implement a competency program, monitor the proficiency testing, perform periodic site audits for program and regulatory compliance, and remove locations as necessary, take away their point of care. Assist the IT or electronic medical record group to develop point of care testing result reporting and making that kind of standardized. These are all things that the point of care team will get involved in. In terms of staff training and competency, as I said before, this is one of the biggest issues for any point of care program, especially in large institutions, because of the large number of sites and the large number of testing staff turnover, and staff resistance, especially from physicians. They feel that they're busy. I know how to look in a microscope. I know how to do a urine dipstick, and you'll find out they're the worst at doing a lot of this stuff. They do a dipstick and they don't wait 60 seconds to actually read it. They read it immediately, which is useless. Initial training and competency assessment for all users. For provider-performed microscopy, doing initial training and competency assessment for providers in that vein can be very tricky, especially getting them to sit down for 15 minutes to a half an hour to demonstrate that they can actually do it. We did this through medical staff credentialing, and basically that's a group within the medical center that provides physicians with a list of procedures they are credentialed for. So you wouldn't have a radiologist doing bone surgery. They wouldn't be credentialed for that, but they'd be credentialed to read an x-ray or a CT scan or something like that. So we had the medical staff credentialing committee look at a person's training and whether they had been performing the test in the past, and maybe there was a test that we put them through, and once they passed that, then they could get credentialed for a couple of years to do it, and then they had to re-up their credentials if they wanted to maintain provider-performed microscopy. You need to do those Q6-month, the initial 6-month, and annual competency assessments. So for nurses, easiest way is to do like a competency fair, where kind of the nurses all come on their break whenever they can and come by and get competency for all the tests that they would be doing. For provider-performed microscopy, an online provider assessment or proficiency testing, as we said, that's a little tricky. Might be easier to just do everybody on some kind of online test. We use the University of Washington system where they actually have a 5-slide test that the providers could take once a year, and they would change, and they had to get 80% right. And if they did, then the medical staff would credential them. Okay, the point of care coordinator, the right hand to whoever the director is, really requires an individual with some unique skills. Definitely laboratory technical competencies, with a thorough knowledge of laboratory regulations and standards, and good experience in test validation. Need to have a lot of customer service skills, so really good verbal and written communication skills, comfortable in communicating with all levels of staff, because you're going to be dealing with physicians and chairs and nursing supervisors and nurse managers. You've got to be able to be comfortable with dealing with all those levels of individuals. The ability to produce a cooperative partnership with the patient care staff. And you've really got to have good conflict resolution skills, because conflict is going to come up a lot in point of care. And there's going to be resistance. Oh, I didn't think we had to do it this way. No, you have to do it this way. You need to be able to go through those conflicts and without ticking people off. Leadership and team building skills. So quality improvement, Lean, Six Sigma skills are always a plus, not required, but useful. They should be good teachers. You're going to have to be teaching how to do testing to lots of different individuals, some of which have never done a laboratory test. So being able to be a good teacher is useful. Good problem solving and resolution skills. This test is going wonky. The nurses can't get the controls in, what's going wrong. You need to be able to go in and troubleshoot every aspect from, how are the sample kits stored? How are they QC'd? How are the QC materials stored? You need to go through each place where things can fail and be able to problem solve and create a resolution. They really need to be self-motivated and work independently. This is probably the biggest challenge for a point of care coordinator, is you've got to really kind of see the things coming at you and deal with them without necessarily involving a whole bunch of other people. There will be things that, you need to take back to the committee or take to the director, but a good point of care coordinator will do this on his or her own day. Okay, point of care inspections for any site doing moderately complex tests every 2 years. College of American Pathologists will do it. They do have a separate checklist for point of care. And as I mentioned before, they do not recognize wave classification and require that all tests be handled at a moderately complex CLIA level. The main thing for that is you're going to have to do proficiency testing. Even though wave tests don't require proficiency testing, CAP's going to expect that you do it. The Joint Commission, they recognized wave tests and survey accordingly. So I've got a site doing a urine dipstick. They don't have to do proficiency testing. COLA predominantly does inspections on physician office practices. We've mentioned them before under management, and that's all I'll say about COLA. Okay, let's take a breather there, and then when you come back, we'll go over the top 10 CAP point of care deficiencies and how to avoid them. Okay, so we're going to start with number 10 and go down to number 1. So number 10, about 3%, all reagents are stored as recommended by the manufacturer, including wave tests. So the first problem is failure to document storage temperatures in all storage areas, and that includes material services. So, if they're stored in a cabinet, you need to be monitoring in the cabinet. If they're stored in the refrigerator, you monitor the refrigerator. If it's a freezer, you're monitoring the freezer. If they're stored, in a box on the floor, you better be monitoring the temperature at the floor. So making sure that all areas are monitored, keeping temperature logs or graphs that then you can check during site reviews to make sure that they are monitoring their temperatures. You may invest in a remote monitoring system. They did at UCSF, where all the refrigerators and freezers were on a Wi-Fi enabled temperature monitors, and so you knew immediately when anything went out of control. If there's gaps, so like in clinics, they may not be open on Saturdays and Sundays over the weekend. So how do you account for, say, like temperature checks that are supposed to happen every day when the site isn't even open? Well, one would be to use min-max thermometers that actually record what the highest temperature they hit since they were last reviewed, and the minimum. And so when they come in on Monday, they can check that no, nothing went above the level of storage requirement or below the level of storage requirement, and you can document that. Again, a remote monitoring system can help with that because it records continuously. Monitoring bedside storage. So you may, in an ICU or in some units, you may have glucose monitoring or urine dipsticks or something stored in the patient room. How are you going to monitor the temperature in the patient room? Well, one way to do this is to get records from facilities, because they are monitoring the temperatures in patient units. They don't want patients to get too hot or too cold. And so you can go to them and ask for those records that demonstrate that the temperature is maintained at, between 69 and 73 degrees, and that's within your storage limits, so you're fine. Okay. Number 9, another 3%er. Laboratory integrates all proficiency testing samples within the routine laboratory workload, and the samples are analyzed by personnel who routinely test patient-client samples using the same primary method systems as for patient-client donor samples. So, typical problem is the proficiency testing is not integrated into the workflow. And the easiest solution to this is for point-of-care staff to take around the proficiency testing materials and hand it to Nurse Jones. You're doing this proficiency testing. Go ahead and do the test right now. You've got to be aware, though, of, remember, the PT sharing issue that I brought up in management, where if you have 2 separate CLIAs, they should not pass proficiency testing materials or results back and forth between those 2 separate CLIA locations. And in fact, to the point of you may not even want all the proficiency testing materials. In fact, you probably don't want all the proficiency testing materials to come to the central lab and then be distributed, because they came to one CLIA and then went out to different CLIAs. That would be considered potentially sharing. So you want to have the proficiency testing materials delivered to each particular site if possible. The PT is always performed by one or only a few of the users, not all the users. So again, having the point-of-care team go out and assign on different shifts, different individuals, keeping track of who did it, so you cover all sites and all shifts, or have some kind of annual rotation schedule can get you through that one. Number 8. When applicable, all patient results are reported with accompanying reference, normal, intervals, or interpretive ranges. So the first problem comes up with interface tests. You've got to make sure that the electronic medical record, when it takes a point-of-care test result in, already has the embedded normal ranges, so they are displayed with the result. That's one. So for interface tests, you can do that. For non-interfaced and manual tests, especially the ones done by physicians, things like stamps or stickers. So you have a stamp, you stamp the chart, and that stamp lists the normal ranges for a glucose. So I'm Dr. Hamill, I did the glucose, I stamp it, I put down the level, and right there on the stamp it's got what the normal ranges are. You could have point-of-care test recording sheets in the kind of the laboratory section of the record that list by test or on a single sheet all the normal ranges. Some places use an actual chart divider. So you have a tab that here's all the point-of-care test, and that plastic or whatever it is divider then has all the normal ranges listed. Problem with that is then, oops, we changed the normal range on something. Okay, now I have to reprint all the dividers and trade them out all over the institution to make sure the right one's in. And what normals do you actually list? So for like an activated clotting time, do you list the normals, or do you list the therapeutic target ranges, because that's what the anesthesiologist in the OR is interested in, or both? And I would suggest doing both. Okay, number 7. If the laboratory point-of-care program uses more than one instrument method for a test for a given analyte, the instrument methods are checked against each other at least twice per year for correlation of results. This applies only to non-wave testing, so don't worry about urine dipsticks and those kind of things. And the problem here typically is comparisons are not done. And a simple solution for this, although the point-of-care staff doesn't like it, is to actually have the point-of-care staff do this. Bring in glucose meters from a couple of different locations, test them side by side, and show that they correlate. bring in ACTs from the OR and from radiology and make sure that they correlate side by side, and do that twice per year. Missing some embedded tests. So like if you have an iStat that has multiple analyte tests, you may need to say, well, I'm doing potassium on an iStat here, and I'm using a Piccolo for potassium over here. You need to bring those together and make sure that every analyte on each one has been correlated. And making sure that all the tests are covered in the process. Who to compare with? Well, that depends on your CAP-CLIA structure a little bit, because this is within a CLIA, okay, or within a center controlled under a CAP inspection umbrella. So you're not required to necessarily say, oh, gee, I have to go and get a glucose meter from this remote location and bring it in and do a correlation. You might. But there's no requirement to, because they probably have a different CLIA than the one that's in the laboratory, and the requirement for making sure that methods correlate is within a CLIA, not between CLIAs. Although there may be a good reason to do it between CLIAs, but I'm not going to go there with that. And then compare all sites against the main lab, maybe, understanding that in some cases, they aren't going to correlate very well. These are different types of tests. They have different nuances and may not correlate entirely with the main clinical lab, but that's maybe a good starting point. Okay, number 6, there is documentation and review of all policies and procedures by the current laboratory director or designee at least every 2 years. So the first problem was this was changed by CMS for sign-off by a director whenever a policy or procedure is changed and reviewed of unchanged policies every 2 years. So this means that whenever a new procedure or policy is changed, let's say within the central lab, the laboratory director has to sign off on it before it goes into use. If there are no changes for 2 years, then the laboratory director goes through and signs all those off, usually in one fell swoop, that yes, they have reviewed them, there had been no changes in 2 years, and now you've done your biannual audit and everything is good to go. So for point-of-care sites, this becomes very tricky because you've got all these distributed sites all over the place. You want to make sure that they're on the current version. So one method is to have online locked PDFs of the approved procedures and replace them when any changes are made. So you only replace them in one place, making sure that the appropriate CLIA director signs. So if you're doing a blood glucose procedure and the director for the inpatient point of care signed off on it, maybe that's the lab director, well, you still need to have somebody out in the remote sites who is the director there sign off on it also, to make sure that the named director is the one who is signing off on things. And then typically a good thing to do is when you're doing site audits is to go through and look at their procedures. If they're printing them off, you want to make sure they've got the current one. If they're online, making sure that the staff know where to find them, how to get to them. And so in an inspection, they won't be going, gee, I don't know where it is. Okay, a complete procedure manual is available in all work areas. This is number 5. Staff don't know where the procedure manual is located on each unit or clinic. So again, as you're going around, if it is a hard copy manual, ask the staff where it is when you do your audits. Nurse Jones, where's the point of care testing? Oh, it's right here on this shelf. Okay, great. If they're online, being able to demonstrate that they know how to get to those procedures and be able to show that to an inspector either doing audits or in an inspection. Okay, the procedure manual is not kept up to date. Again, this can be handled by, if it's a hard copy, point of care staff delivers updated procedures to all the testing sites and physically takes the old one out, puts the new one in. If it's electronic versions of those procedures and they're all online, just need to have a way to get to them. You can download PDFs to a local computer. Some places do this because they're worried about like the main system going down, the internet going down. Well, then I still have them on my local PC and I can bring them up should I need to. And again, checking manuals for being up to date during your site reviews. Okay, number 4, control results are documented for quantitative and qualitative tests as applicable. So failure to document the external quality or external control results is a problem that virtually every point of care system has. So you can use instruments with QC lockout. They will log the QC when it's done, and if you don't do the QC after 24 hours, the machine locks up. And you have to ask somebody with special privileges to then unlock it so that they can do the QC and then keep going. Interfaced instruments, if you have something that can interface to the EMR, then it can transmit that quality control data centrally so it can be reviewed centrally. You may have paper logs for recording the QC manual tests at required intervals, and monthly review of those logs with staff and re-education if they aren't doing it is part of your site audit process. Okay, another problem for number 4 is failure to record an internal control with the test results. Again, especially physicians are guilty of doing this. So again, having a stamp or a sticker for result reporting that includes, okay, you need to include the control result down here, doctor, and initial it or something. And building that control reporting into the electronic medical record with a hard stop, that if they're entering it in, okay, I'm entering in the results of my PPM, that would be a good one because there's no internal control. I'm entering a result from my ACT, and now I've got a hard stop that says what was the control. And I've got to fill that in before I can go on. Okay, number 3, calibrators, reagents, and solutions are properly labeled as applicable and appropriate with the following elements. Content and quantity concentrations are tighter. Storage requirements, date prepared and reconstituted by the user, and the expiration date. The first 2, the vendors are going to do. You don't have to really worry about those. The date prepared or reconstituted is the date that was opened, and the expiration date. Those need to be listed because they change depending on when it was taken out of the refrigerator, when it was opened, when it was reconstituted. And typically staff are going to fail to properly label the reagents. So site audits and re-education, if they're having failures, maintain a central control of supplies and label them prior to periodic delivery to sites. So you might have pH paper. Okay, I'm going to say that this pH paper expires 6 months from today's date. I'm going to write that date on and distribute them out. And then 5.5 months from now, I'm going to deliver a whole new case of pH paper to all the units that use it, take away the old stuff, and now they are good to go. Reagents that have different out dates depending on storage. So it's 6 months in the refrigerator, but once you take it out to room temperature, it's only 7 days. So you need to be able to redo the expiration date on those. And so date stamps to indicate a new expiration date may be a solution to that. I mentioned this one already, reagents without expiration date like pH paper. The lab sets the date and distributes it out in one fell swoop, gathering all the old stuff in, and then whatever, before the next expiration date, go out and give it out again and bring the old stuff back in. There is a documented program to ensure that each person performing point-of-care testing maintains satisfactory levels of competence. And the problem is that the requirement to assess all 6 elements of competency for moderately complex tests, so direct observation, monitoring and recording and reporting of test results, review intermediate results or worksheets, that's usually not a problem with point of care, direct observation of maintenance and our function checks, assessment of test performance, and evaluation of problem-solving skills. Very hard to do. Competency fair where everybody's going to come and you kind of run them through the same process and ask them to demonstrate, okay, if X happened, what would you do? Show me how you do a test using, say, Coke and Diet Coke. One has glucose, one doesn't. You can use those as surrogate tests. Not that it'd be appropriate to use those for testing, but you can do things in a competency fair that can demonstrate all 6 elements of competency, using controls as surrogate unknown samples, and then instrument logs, when a user performs a control on the instrument, can be useful to show that, yes, they know how to do the controls. I've got it logged that Nurse Smith actually did a control last week and it was successful. So there I can demonstrate that they were able to do that. Okay, the number one, almost 8% of labs get hit with this. The laboratory's current CAP activity menu accurately reflects the testing performed. This is point of care creep, where you have a new site just start doing testing without anyone knowing about it. A site that's doing testing just deciding they're going to do a new test, and so they bring in something. The doc decides they want to do XYZ and they're going to bring in that because someone said it was really good without telling anybody. Or one site says, oh, hey, I need that test, but I don't do it on my unit. Can you bring it up and do it on my unit? Or can you send it up and show me how to do it on my unit? Well, they're not approved for that necessarily on their unit. And so, this is what we call point of care creep. This is where having supply and purchasing involved in like the point of care committee can be very good. They can have a list of, say, all the sites that are doing each individual type of test. And then if they get requests for supplies from a new site, they can go, oh, wait a minute, red flag here. Well, you're a new site. Did you get approved? What's going on? Strict institutional policies, and that if you start up point of care testing without going through the proper channels, getting the proper authorization and approvals, you may be barred from doing point of care testing for 6 months, and then you can reapply. Doing the point of care site audits, having a list of approved sites and tests they can perform listed at each site. So as part of their procedure manual, they should have, this is the list of tests that can be performed in this clinic. Urine dipstick, provider performed microscopy, KOH and a wet mount, a hemoglobin on a HemoQ, and that's it. That's all you're going to be able to do at that site. And then if you go and do a site audit and see that they're doing something else, it's very apparent that they're working away from what they've been approved to do, and you can stop that. The CAP electronic activity database may not accurately reflect testing. So when in CAP inspections, you're giving them information and their database needs to be updated. You've got to be very careful when entering and reviewing that electronic submission to make sure it's really up to speed for what's actually occurring. Review the test list periodically for each site, and add the CAP activity menu update for any new test validation. So as you validate a new test and bring it in, one of the process control points is going to be, oh, did I update that CAP activity menu and list that as a new test that we're doing? Things that are going to change on the test menu just before an inspection. The team may not be aware of these changes. My recommendation is you got an inspection coming up and someone wants to add a new test. Why don't you just delay that until after the inspection, then go ahead and add it, and then everything will be copacetic, no problems with it. Okay, that is the end of point of care. That's a lot of stuff to go through. It's a very wide open area in laboratory testing that is continuing to evolve. And interestingly, in California is an area where licensed laboratorians may play a much larger role in this, either as point of care coordinators or on a point of care team, or maybe as a point of care wave test laboratory director for pharmacies or other places that want to do this testing. So if you have any questions, drop me an email and I'll be happy to answer anything, and good luck.